Hello guys, I am Deepak Shukla. Welcome to our channel Study Mania. So many people are advocating for HPV vaccinations. Today, let's know why it is important. Here, we'll learn about cervical intraepithelial lesions. So what is CIN? CIN is a spectrum of intraepithelial changes that begins from minimal atypia, and progress to invasive squamous cell carcinoma. Okay, so from minimal atypia to invasive squamous cell carcinoma, and it is usually seen under the age of 40. That's why it is very important to take HPV vaccination. Okay, let's see etiopathogenesis. So mainly it is due to HPV virus. Okay, HPV virus and environmental factors also plays a role. So if they ask you pathology, we have to draw this diagram. Okay, so how is it going to affect? This is a HPV virus, it is a DNA virus. Along with this, some environmental factors like multiple sexual partners, sexual activity at very young age, high parity, persistent infection and exposure, duration of exposure, immune status and genetic susceptibility. Okay, so all these environmental factors along with HPV that will cause CIN. In HPV, we have two things, low risk HPV and high risk HPV. Lower the number, lower the risk. Okay, 6 and 11, low risk HPV. Higher the number, high risk HPV. 16 and 18 is high risk HPV. So this low risk HPV, this will cause laryngeal papilloma in newborn, whereas it may also cause episomal infections like condyloma acuminatum in vulva, perineal lesion and perianal lesion. When it comes to high risk HPV, that will cause CIN and later cause CS cervix. How does it cause? This high risk HPV, they will increase E6 protein and E7 protein. When the concentration of E6 protein is increased, there is degradation of TP53. And when TP53 is degraded, there is upregulation of telomerase that will cause the cell to become immortal. Okay, the cells will not die anymore. When E7 is increased, there is inactivation of RB gene, okay, and inhibition of cyclin dependent kinase inhibitors P21 and P27. So you can remember 7 into 3, 21, and approximate like that 27. Okay, and this increased concentration of E7 that will cause DNA repair impairment. So okay, now cells are not dying and the DNA cannot be repaired, and this viral integration, this will cause dysregulation of oncogene, that is MYC gene, and that will cause LSIL. Okay, and if this LSIL, when there is persistent infection, that will cause HSIL and then invasive carcinoma, and then it can cause metastasis. So this was about the pathogenesis of CIN. So we have talked about this environmental factors, that is presence of co-carcinogens, that is cigarette smoking, coexisting microbial infections, dietary deficiencies, hormonal changes, and use of oral contraceptives. So this was about the pathogenesis. Now coming to the classification. Earlier we had CIN1, CIN2 and CIN3 depending upon the epithelium involved. Okay, when lower one third of the epithelium was involved, it was CIN. When 1/3 to 2/3 was involved, it was CIN2, and more than 2/3 was involved, then it was CIN3. After that, in Bethesda classification, they have said CIN1 as low grade squamous intraepithelial lesion, LSIL, and the CIN2 and CIN3 have been given a name as HSIL. Okay, so this was about the classification of CIN. If someone asks you what are the markers of CIN, so actively dividing cells of basal layer, they will produce Ki67 and overexpression of P16 gene. Okay, P16 is cyclin dependent kinase inhibitors. So here you can see CIN1 only 1/3 is involved, CIN2 1/3 to 2/3 is involved, CIN3 more than 2/3 is involved, and there is invasive carcinoma. Okay, so what is the morphology? We'll see the normal cells, after that LSIL, then HSIL. So what are the microscopic features? We'll see nuclear atypia. Here you'll see coilocytic atypia. Here what will happen? The nuclear atypia accompanied by perinuclear cytoplasmic halo, that is known as vacuolation. And why is this perinuclear cytoplasmic halo? It is due to extensive cytoplasmic destruction by HPV encoded protein E5. Very important, protein E5 will cause halo around the nucleus. Okay, what other things you can see is the nucleus of coilocyte is enlarged, wrinkled with an undulating nuclear membrane and rope-like chromatin. Other things we can see is pleomorphic nuclei, hyperchromasia, coarse chromatin granules, and loss of polarity. Coilocytes are absent in many cases of high-grade dysplasia and all invasive carcinoma. Okay, so coilocytes are present in LSIL but not in HSIL or invasive cancers. So here you can see this is nucleus and surrounding this is a halo. Okay, so this is atypical squamous cell. Again you can see this is nucleus and there is a halo. Okay, so these things you can see. There is pleomorphism. Okay, size of the nucleus is increased. So this is about the microscopic. Coming to management, first we have to go for investigations. So investigations, management guidelines according to WHO. In limited resource countries where the resources are limited, first we have to go for screening with HPV DNA and plus minus VIA, that is visual inspection with acetic acid, and then we have to do the management. Biopsy is not mandatory in limited resource countries, but in resource rich countries we have to take the pap smear. If the pap smear is abnormal, go for the biopsy, then grade the carcinoma and then manage. Let's give 2 minutes for pap smear. So pap smear is the instrument used for pap smear is Ayer's spatula. Okay, Ayer's spatula, one side there is a brush thing and other side there is a spatula, okay, bifid spatula, and then endocervical brush. The fixative used in pap smear is 95% ethyl alcohol plus minus 5% ether. In samples we have to take it from ectocervix also and endocervix. In ectocervix from transformation zone with bifid end of Ayer's spatula, then near the external os, and then rotate 360 degree. From endocervix how to take? We have to take it from the endocervical brush. Note, do not air dry the slide, and PV examination should not be done prior to pap smear as that will change the findings. Now if pap smear screening is abnormal, we have to go and do perspeculum examination. If growth is positive, get the punch biopsy done, and if there is no visible abnormality, we have to do it under colposcopy. Okay. Now coming to HPV screening. Before HPV screening, I'll tell you what you'll see in VIA, visual inspection with acetic acid. So in normal epithelium, it will take pink color, but if it is dysplastic or metaplastic, the color will change to white and gray. Okay, dysplastic, white and gray in metaplasia. Whereas in visual inspection with Lugol's iodine, the places which are stained are normal epithelium and the places which are not stained is dysplastic epithelium. So you have to keep in mind before moving to the screening. So according to the WHO protocol, this HPV screen starts at 30 years and until 50 years we have to keep on doing. There are 3 approaches of screening. In see and treat we have 2 things, and the third one is see, triage and treat. In see and treat, the first thing is with HPV DNA testing and the second is with visual inspection with acetic acid, that is 3 to 5%. Okay, this is done in from 30 years to 49 years, and this is the primary test. If it is positive, then we have to do LLETS, means large loop excision of transformation zone and large loop electroexcision procedure. Okay, if it is negative, then we have to repeat the process in 5 to 10 years or 3 to 5 years in HIV patients. Same thing coming to VIA. If it remains pink means normal epithelium, so we have to repeat the test every 3 years, but in HIV patient do it earlier. If after VIA the place appears white, okay, aceto-white, then we have to do it with LLETZ, okay, large loop excision of transformation. In see, triage and treat we have 2 tests, primary test with HPV DNA testing and secondary test with VIA. We are going to do this secondary test only if the primary test is positive. Okay, so if primary test is negative, we have to repeat it like here, and if the primary test is positive, we have to do VIA, and if VIA is pink means it is normal, that we have to repeat the HPV DNA every 2 to 2 years. If VIA is also positive means it has become white, then you have to start the treatment. Treatment is LLETZ, cryoablation and LEEP. According to ACOG, screening starts from 21 years. Okay, so we have to take the pap smear, repeat every 3 years from 21 to 30 years, almost 3 times. Then from 30 years to 65 years, we have to do co-test. Co-test involves HPV DNA testing plus pap smear, and we have to repeat this every 5 years till 65 years of age. So this was about the management, line of management, how to investigate. Coming to procedures, it is very easy. The first thing that we'll do is cryoablation. by putting carbon dioxide or nitrous oxide with cryogen to the dysplastic areas. Okay, it is done only in CIN1 and with non-HIV patients. Okay, principle is very simple. We have to freeze the intracellular water in dysplastic areas that will destruct the dysplastic epithelium, and it is done at very low temperature. So we have to freeze for 3 minutes, then thaw 5 minutes, then freeze again. The side effect of cryoablation is persistent water discharge. Coming to large loop excision of transformation zone and loop electroexcision procedure, it is done in CIN2 and CIN3. Here total dysplastic area is removed by passing the current that will cut and coagulate at the same time. So this was about the procedures. Now coming to the favorite topic, that is HPV vaccines. We have quadrivalent vaccines, means 4 things are involved: 6, 11, 16 and 18, that we have seen while reading pathology. So here we have Cervavac and Gardasil. Bivalent vaccine that are taking only high risk HPV, that is Cervarix, and non-valent vaccine that will have 6, 11, 16, 18, that we already know. Along with that 31, 33, 45, 52 and 58. This is Gardasil 9 and this is most commonly used in US. All these vaccines are prepared from L1 capsid protein. Okay, so depending upon the age, the doses are required. So if the age is less than 15 years, only 2 doses are required, that is 0.5 ml IM in the 0 month and then 6 months. If the age is 15 to 26 years, then 3 doses are required, that too at 0, 2nd month and 6 months. The contraindication of HPV vaccine is pregnancy, and the vaccine is approved by FDA till 45 years. The common side effect of this HPV vaccines is syncope. Okay, so there are many queries about HPV vaccines that you can ask your physicians. So here are some pics of Cervavac 6, 11, 16 and 18. Gardasil, that is commonly used. Types of vaccines here: Cervarix, that is bivalent, only 16 and 18 is used, from GlaxoSmithKline. Gardasil, that I am saying 6, 11, 16 and 18. And Gardasil 9, so many things are there: 6, 11, 16, 31 I have told. Okay, so these are the vaccines available for HPV DNA virus. So this was all about the CIN, and if the procedure is not done and if it is left untreated, it can go to CA cervix. Okay, so learn about CIN and please don't take it leniently. Get your HPV vaccination done. Thank you so much.